I'm joined today by Liz Perry from the Speech and Language Accent Group, the STAG Clinic. I will be your host today, Danielle Morales, licensed educational psychologist at the Byland Clinic. And we're so excited to have Liz today to learn a little bit more about her work and expertise and practice. So, Liz, you're the founder and director of STAG. So can you talk through what inspired you to start your own clinic and what's the philosophy your team uses when partnering with parents in the community?
Hi, thank you for having me. It's a pleasure to be on the show. Now, I'm Elizabeth Perry, and I'm the director and founder of Speech Therapy and Accent Group. And I started STAG back in 2016 when I was a newly single mom. And I knew that I needed a higher earning potential and a more flexible schedule for my two young children, more than I could have if I were to be working in a school or a clinic. And I also knew that the philosophy that I wanted to have in my clinic was going to be different than what I had experienced in the workplace before. I wanted to be a team with the parents more than what I had seen previously, sort of like a previously it was like send your kid into the therapy room for an hour and then you were done for the week. But if you think about it, your kid comes into the therapy room for 1 hour and then the parent is with that child for the remaining hours of the week. And so there's so much therapy that can be happening just in those between hours. And I wanted to be able to partner with parents. And so I wanted to be able to start this company with this core philosophy that parents aren't just spectators, but they're essential partners.
Mhm.
And I wanted families to be able to be seen and supported, not like they're just kind of moving helplessly through a system.
Mhm.
And STAG has sort of become all of these things. It's it's afforded me this flexibility that enables me to be the mother that I can be and that I want to be. It affords me to be the primary breadwinner in my family of seven while my husband is in medical school. And it affords me the ethical practice that I want to have. And it allows me to partner with families in a way that feels good to all of us, where parents can really partner in the therapy experience and feel seen and heard in the process.
Mhm. I love the idea of bringing parents actively into treatment. We do that a lot with different therapy techniques and psychology. What does that look like at a high level in the speech and language world with this parent partnering? What are the kind of interventions or practices, for example, at a high level that you might do at home?
Well, we'll co-treat in therapy, and then at the end of therapy, I'll ask, what is it that you really want to prioritize and do this week? And we'll kind of powwow at the end and figure out what it is that they want to do, and then they'll model that. And then during the week, if they have any questions, then they can always email or call. But we kind of, during and throughout the session, figure out what their highest priorities are. And so they're going to prioritize or do the kinds of therapy that are the highest priority to them, right?
Hmm. Hmm.
And they're going to do it in ways that are most meaningful or doable for them. So if I were just to tell them, sit down and play with your child, but they're working full time or they're busy running errands all week, they're not going to be able to do that. But if they say, well, I can do this when I'm in line at the grocery store,
Hmm.
then let's find ways to make that a priority.
Hmm.
So
Hmm. Yeah. So
they need,
really practical, meeting people where
yes.
they are on the ground. Hmm.
Right, but if we're going to do that, they need to feel like they have the power and the authority to bring that to the table.
I love that. I know that parents get really overwhelmed by not only their own schedules, but if you also have a child that's neurodiverse, there may be multiple therapies that you're getting your kid to after school or on the weekends. And so trying to integrate things naturally into a work day or, weekend, I can imagine how useful that is for parents. So that's a really cool approach. So another thing I wanted to ask you about, I saw that you recently wrote evidence-based therapy guidelines for young children with autism that were adopted for use across China. So that's super cool. For parents listening, what are a few of those gold standard practices they should look for in their child's early intervention therapy? So what can we extrapolate out from those standards to practices here in the US?
Yeah, that was a very cool project that I was really fortunate to be a part of. And this is international. I mean, any kind of early intervention speech therapy for autism or just for any child ages, say, 0 to 6, that interaction with that child really needs to be child-led and relationship based. So communication is always going to come before speech. And the goals that we develop for that communication are going to be focused on quality of life. So it's probably more meaningful to develop goals around playing with your child as opposed to getting them to say bah, because that's not going to focus so much on quality of life, right?
Mhm, mhm,
Furthermore, there needs to be some kind of respect for neurodiversity. So if your child is, say, on the spectrum and they really enjoy playing with you by walking back and forth from one end of the room to the other, as opposed to just sitting in place and trying to make eye contact, that's something that we can honor. And that's great.
mhm, mhm,
The best interventions oftentimes are going to look like ones that are focused on fun and play and joy as opposed to like focusing on compliance, for instance. So we're not, I'm more focused in my therapy and early intervention on us enjoying the interaction as opposed to like following a direction. Like, I'm not going to tell a child, okay, now you have to put the ball in the box, but we're just going to see what we can do to have fun with one another. And I'll document that as a really successful engagement with that child if we're enjoying each other's company.
mhm, mhm. So really a neuroaffirming approach is what I'm hearing, very neuroaffirming.
Yes.
Um, and with those guidelines, is that something that we're able to view if our listeners are interested, or are those published in Mandarin? Like, are those accessible to the US audience?
They are published in Mandarin, and I am not even able to read them. I actually have them like right here on my
Oh,
desk,
that's
and
neat. Yeah.
I cannot read them because they are in Mandarin. So,
Yeah. Yeah. But
yep.
it's really neat to hear the cross-cultural component of, again, this neuroaffirming approach, not necessarily trying to fundamentally change who a child is, but improve their quality of life, honoring who they are, and despite, the challenges that their disability may arise, and that is universally impactful. So that's really neat.
Yes, yeah, we can do that while being very respectful of the cultural norms within that are deeply, deeply embedded in the culture of that country, just because there are a lot of firmly held beliefs there within mainland China that we have to respect and be very careful around. And that's a beautiful part of who they are just as a people. And also say, hey, here are some additional things that we can try on top of some of the things that you are already doing that we can add to your repertoire to
Mhm,
try. So
mhm,
just
mhm.
lots and lots of richness to add to this I don't know, beautiful way of language living.
Mm-hmm. Well, that's a really neat project. Another area I know that you specialize in is early intervention. So,
Yes.
what are the most critical milestones parents should be watching for in toddler years, and when should they seek an evaluation? And for this context, a speech and language evaluation, but also if you have other notes on maybe when it's time to seek a neuropsych eval or something broader, that would be really helpful too.
Yeah, yeah. Oftentimes you'll hear from your pediatrician to wait it out, and that's okay. That's okay. My personal philosophy is when in doubt, check it out. Sometimes when you call a professional, there's a minimal consult fee. And I personally, just as a parent, would rather pay a consult fee minimally just to have peace of mind. Other professionals, you can just call and have a free consult fee. And like myself, if you call me, I will talk to you however long you want to talk on the phone and alleviate some of your worries with you. And if that helps you to sleep better at night, just to help alleviate some of those concerns that you have, your child is developing normally, or see if it's maybe time for an evaluation, then great. But when in doubt, check it out. So by 12 months, you should be hearing a lot of babbling. By 18 months, you should be seeing a lot of pointing at things with a closed fingers and pointer finger extended. By 18 months, you should hear about 5 words or so, and toddlers should be responding to their name when called consistently, like stopping their play at minimum, and typically turning their head toward the speaker. By 24 months of age, you should hear about 50 words or so and some 2-word combinations. So, as parents, you don't need to memorize some milestone chart per se, but I would say trust your instincts because you have a PhD on your child. You're the only one with a PhD on your child. The pediatrician doesn't, therapists don't. So if something feels off, just make a phone call to a therapist. And if they're not the right person to call, then maybe they can refer you to someone else who might be the right person. And also
Mhm.
keep in mind that if you do get an evaluation, it's not committing you to therapy. It's just
Mhm.
going to give you, say, more information.
Hmm. Yeah, I like that quote. If in doubt, check it out. I mean, one of the things I hear a lot from our clients is when they bring up concerns to their pediatrician, and this is not to knock pediatricians, there's amazing pediatricians out there, but
Yes.
I do hear in our population sample a lot of parents sharing that they were told to wait on things. Like, let's just give it some time. Let's just give it some time. And that feels really disempowering because they do want to move forward with early intervention. So when you say seek, outside opinion, would that be an example, let's say? So for example, you bring up to your pediatrician, they're just not paddling as much as I would expect. When I take them out, with other kids their age, they seem a little bit behind. Is that a situation where, if the pediatrician says, oh, let's just wait, it seems fine, to maybe go ahead and pick up the phone and call a clinic?
Yeah. Yeah, it's really scary because there's no handbook on what to do if your child isn't meeting milestones.
Yeah.
And so oftentimes all you can do is just hop on the internet, but the internet is this big black hole of terror. And as soon as you get on the internet, you go down this big rabbit hole of like one minute you're just getting on the internet and typing in, my kid isn't meeting their milestones. What next? And
Hmm.
next thing you know, it's like cancer,
Yeah.
autism, and you're like, ah, it's very
Hmm.
scary.
Hmm.
So you just hope in that you find someone, some therapist or professional on the phone who's going to be compassionate and listen.
Yeah.
Yeah. So if you do make a phone call, everyone out there listening, you can always call me, regardless of whether it is a speech therapy concern or not, and I will hopefully be able to direct you to the right person or someone who will know the right person and get you on the right track because it is hard enough being a parent and worrying about things. It's just a sign
Hmm.
that you're a good parent and worrying is just one thing that you don't need to deal with. Hopefully, we can find you the right person to talk to.
Mhm. And reaching out for help is such a big deal, right? And so I
Yes,
always do feel
yes,
disheartened when a parent brings something up to a primary care provider, for example, and it's dismissed because
yes.
asking for help is really courageous. And like parents don't want to hear that anything is wrong, right? Like that's a fear. And so to even open it up for further examination is making yourself vulnerable. So to not be met with compassion.
When providers are not meeting parents with compassion.
Yeah, I'll just start from there. So, asking for help is a really courageous act. And, even bringing something to the concern of your pediatrician or doctor can be a really vulnerable moment because parents don't want to hear that, something is wrong. So, to open your child and yourself up for that sensitive conversation can be difficult. So I just want to recognize that too. And so I love the idea of if you just hear no, or feel like the concern was not adequately addressed from one person, there's just a wealth of resources out there of reputable people, and you can just pick up the phone and talk with somebody else. I'm curious if you do get a phone call from a parent that says, hey, there might be some missed milestones, or some of these things are later, right? That my child's not pointing, they're not responding to their name. Can you give some examples of typical follow-up questions that you might ask a parent in that situation?
Yeah, oftentimes there's some kind of differential diagnosis going on where I'm trying to decide, well, am I going to be the right person to talk to about this, or should they be following up with somebody else? So oftentimes I'll ask if I'm the first line of defense, like, have you talked to your pediatrician about this? Have you talked to anybody else about this? I will ask some other questions about this, like tell me a little bit about their talking and sound history. Tell me a little bit if they've been pointing. Pointing is an excellent indicator of future vocabulary growth. And so I'll just try to get an indicator of if they're also meeting some of their other milestones.
Mhm.
Um, it's general things like some of the bigger red flags for things like autism might are they responding to their name when called consistently, not with 100% accuracy, but consistently, most of the time, or following single step directions. So I'll generally ask about that because that might be a sign that they might want to go and talk to their pediatrician. So there are just some general questions that I'll ask, and sometimes those questions are met with, oh no, they're not responding to their name when called, or sometimes they'll say things that clue me into there might be something medical going on. Sometimes it sounds like there might be something with their hearing going on. Sometimes it just sounds strictly like an expressive delay. Let's get them evaluated for some, maybe they need a speech evaluation. And then other times everything is on track and they're just worried, and we have the option to go ahead and proceed with an evaluation, or if they want, they can wait because everything is totally on track with milestones. And so then they sometimes parents decide to wait, and other times they want to move forward with an evaluation anyway. But I want to give them options.
Mhm.
Furthermore, I usually try to tell them about the different kinds of therapy options that they have too. They don't have to go private with me. They have options through Regional Center of the East Bay, which is a state funded option. They can, if the student is old enough, they can go through their school district. So they have a lot of different options.
Mhm. I really appreciate that kind of just initial differential that you through, right? Because, I do think going back to your other comment around our first instinct, understandably, is you see something, you Google it. These days, you might ask AI, and it tells you this is a flag for something like autism. And like you said, it totally can completely be. And that's why it's so important to talk to a professional because there's so many layers of nuance. Like you just pointed out, like, oh, this sounds more like a hearing component, or this sounds more like this is specific to expressive language as opposed to, more holistic challenges with social language development, or social understanding. So I think that's just really good to keep in mind of why it is so important to actually reach out and talk to somebody because there's so many layers of complexity that are often not adequately explained if you're doing your own research, even though, again, parents are really well intentioned and can sift through a lot of this information. The differential diagnosis can be complex, and kind of outside what you come across by just Googling. Um, Another topic, and I'm excited to hear some information on this. So I know that you hold a specialized certification in augmentative and alternative communication, or AAC as it's usually known. And I hear this a lot. So I'm curious of how you respond. So many parents that I talk to worry that introducing AAC will prevent their child from learning to speak verbally. So is that true? And then how do you address this common fear?
Sure. Yeah. So this is a very common fear, and I get it. I mean, if I thought that there was some scary device and it was going to come in and get in the way of my kid learning to talk, I wouldn't want my kid having that device either. Here's the thing, AAC doesn't replace speech, it replaces silence. Communication is a human right. And AAC provides access when speech is developing. So when we look at research, at parent experience, and at clinical experience, it all consistently shows that AAC often supports spoken language development rather than preventing it.
Hmm. Hmm.
All we're trying to do is just remove some communication barriers using whatever means are most effective. The goal is not to get a child to learn how to use a speech generating device. The goal is to help that child to successfully communicate with any means necessary. But I get it. If the family is still hesitant about using the speech generating device, there are lower tech options like pictures around the home that can be a useful starting point. I have families that have printed out whole sets of pictures of the child's favorite foods, and they post them at eye level on the fridge, and the child will go over and pick out the snack they want. And then the parent opens the fridge, they unlock the fridge, they get out the snack, and the child
Hmm.
has just been successful in communicating what they wanted for snack. And
Hmm.
everybody wins because that child was able to communicate what they wanted, and they were so proud of themselves for being able to do it. So I feel I kind of think about AAC kind of like a wheelchair for communication. It provides access, but not dependence. Say that
Hmm.
someone was learning how to walk and they were getting physical therapy to learn how to walk. You wouldn't take away the wheelchair while they were learning how to walk and getting physical therapy, right? And say, well, the wheelchair is going to create dependence. So we're going to take away that wheelchair. We don't want you to get dependence on the wheelchair, right? The
Hmm.
wheelchair is just means to give them accessibility because movement is a human right.
Hmm. I appreciate the analogy. I haven't heard it explained before, and it's actually something that I didn't have a lot of knowledge on. So I'll be using that analogy, I'm sure, moving forward. Where I'm like, I don't know. Like you said, they'll ask if it will prevent language acquisition, and my intuition on it was more that, like you said, it seems like any way we can enable communication would likely reinforce future communication attempts. Because if you feel that you can't get across your needs, and like you said, you feel frustrated, then that could really really start to build its own issue around learned helplessness and frustration and treatment interfering behaviors clinically. But I love the analogy of likening this assistive technology to other types of assistive technology that I think everybody would agree on, like a wheelchair, for example. So I know another area that you are specializing in your doctoral research. And first of all, congrats on working on a doctorate. I don't know how you have time with running a business and having a family of seven. But so that's really awesome. So one of the areas you're researching is specifically on focusing on improving relationships between school districts and special education and families. Um, and I know that you've worked in both worlds. So why is there friction in this dynamic? How can parents build a more collaborative relationship with their child's school? And what can schools do to reduce this type of friction?
It's really interesting because we have decades of research into family professional partnerships and what makes them successful. And so we know what makes them successful. We know that higher quality family professional partnerships are the results of things like increased trust and clear communication. When IEP meetings are clear and friendly, and that when the parent feels like an equal member of the team, that things go really well. And yet, in practice and in implementation, we still have so far to go. So it's really interesting to see the gap between theory and practice. But, in practicality, IEPs are just such an incredibly stressful and emotional experience for families. And
Mm-hmm.
schools don't always see that perspective. They can't possibly see that perspective because they're not in those parents' shoes. So not to demonize the school. The schools are doing great with the resources that they have, and parents can't see the school's perspective either. So it's on both sides. Parents and schools, they want the same outcome. Um, but they approach the child from those different perspectives.
Mm-hmm.
So one of my mentors, my doctoral mentor, Dr. Megan Burke, she's spent so much of her career studying family professional partnerships, and her work has consistently shown that when schools and families build these trusting, collaborative relationships, the outcomes improve for everybody. And so when parents, I would say if that parents don't need to become legal experts in order to be effective advocates for their children. One of the most powerful things that you can do as a parent is to share what you know about your child very specifically. Bring concrete examples, some work samples, homework concerns, some observations, be very specific. I would assume positive intent initially, but ask questions if something doesn't really make sense.
Mm-hmm.
So, for example, bring sound bites. If you're concerned about something like stuttering, bring an audio recording. If you're concerned about dyslexia, or if you're concerned about reading and writing them, bring some of those samples with you so that the team is able to see what your concern is rather than an accusation, or rather than saying, well, my child can't read well. That
Mm-hmm.
way, the team is actually able to see what it is that you're talking about.
Mm-hmm. Mm-hmm. Yeah, yeah, I appreciate this topic so much. We actually have a newly published guidebook all about how parents can navigate difficult conversations in
Mm,
IEPs, because I think that the word I would use often is trauma. for parents. It's a traumatic experience especially when they've been in a situation where they've been advocating, they feel like for sometimes years. And, there's comments around, well, they're fine academically, or like, we just don't see the child the same way as you do. And parents will describe to me like that they feel that the school is painting them in a way like they're misreporting, or in quotations, they're crazy, like we have this amazing student, like I don't know what's going on at home, but must be something at home. And it just feels so invalidating. And to try to be advocating and worried about your child's future, and to run into what feels like a brick wall, can really add up to so much cumulative stress. We give parents similar consultation around like bringing work samples in, not needing to sign things either way right away, like take it home, read everything over. You can request follow-up meetings. But yeah, it's tricky. I mean, I think a lot of us that work in the private clinical world started our careers in schools, and I've been the school psych that had a completely full counseling caseload. And, you literally do not have the time of day to add another child into your counseling rotation. And yet, somebody else needs services, and maybe really complex services that's a little outside your scope, right? And so it's a really challenging dynamic on both sides of the table. And I think that just leads to such a breakdown in trust, and such a misunderstanding of what the schools, especially I think what they're legally obligated to provide, and what the resource allows them to provide. And likewise, then kind of projecting that back on parents as being entitled or annoying, by advocating really hard for their child for what the school might say. Again, they don't have the resources to service, or what they view as being like a mild disability, or a home-based concern. Because this is really tricky ground to navigate.
Yeah, you're bringing up a lot of some of those implementation difficulties. There are workforce complications that are getting in the way. And then you also mentioned some of those potential, maybe even IDEA misunderstandings where you're so bogged down in the day-to-day, then how are we even interpreting some of these more complex situations that we may not fully grasp? And then there's the whole situation of like eligibility in the first place, trying to understand the minutia of eligibility in the first place. So it's very, very complex. And then on the other side of the table is the parent advocating for their one student. It's very challenging to navigate.
Yeah. I always just try to leave those conversations with parents with that of like, you're doing your best. Like you said, you're the expert in your child, and this is hard. It's a really hard space to inhabit.
Mhm, mhm.
So I look forward to seeing, what your research yields, and any other concrete recommendations that may result, because I think we can all benefit. Um, Briefly, our clinic is specializes in IEE, so I know our listeners are usually pretty well versed. But I'm curious, from the speech perspective, how does a speech and language IEE differ, maybe from something like a psychoeducational IEE? And when should you request a speech IEE specifically, a speech and language one?
I am particularly excited to talk about IEEs. This is the main focus of my doctoral research. My research is on trying to understand the family experience within IEEs, because there's just no research within this area. And if we're going to try to understand systemic change that needs to happen within this particular procedural safeguard, then we have to understand the impact on the individuals whom it's intended for. So, a speech and language independent educational evaluation is just an independent evaluation that's conducted by a speech therapist that's not employed by the school district. The IEE is a procedural safeguard, so it's It's a legal protection that's built into special education law that's meant to ensure that students with disabilities and their families are able to receive fair treatment and to have a way to resolve disagreements with the school districts, just like other procedural safeguards. And it's paid for at public expense, meaning that the district is going to pay for it. So essentially, when a family disagrees with a school district's evaluation, they can ask the school district for a second opinion by someone outside of the school district. And then the school district can agree or disagree to fund that speech language IEE. And if they agree to fund it, then a family can select an outside assessor, and I am someone who does these outside assessments.
Mhm. Perfect. And are there particular areas with speech IEEs that you see come up more frequently? Like areas that are gaps to kind of look out for, or is it just really case by case if you feel like the report that was completed by the district didn't capture your lived experience?
Well, it's pretty different from student to student. Oftentimes the cases are very complex. I would say they're sometimes speech only, but oftentimes there are cases that will involve multiple evaluations. So not just speech, but they'll also involve IEEs for psychoeducational evaluations and occupational therapy evaluations. They're very complex kinds of cases, but in every single case, I can tell you that these families are really hurting. Oftentimes, not oftentimes, every time, they do not feel seen or heard by the school district. There's a huge disconnect between what they're seeing and what they've been told or how they felt in their interactions with the school district. And that, in very large part, has contributed to the IEE. And tensions are very, very high, which makes sense. You know, over half of due process hearings are a result of IEEs. And so it's no wonder that tensions are so high. I mean, these often lead to due process. It's a very tension-filled situation.
Okay. Thank you for giving some examples. That's really helpful. So we've already been talking about this a bit, but because you understand both the clinical side and administrative side of school services, what is your top piece of advice for parents when they are preparing to advocate for their child at an IEP meeting?
I would say, trust your gut. You are not just someone who's been invited at random to the IEP meeting. You have a PhD in your child. You are the only person at this meeting who is the expert in your child, and you can sit comfortably at that meeting as the sole expert in your child.
Yeah, I like the framing of you're not a passive participant. I think that that's really important if you're an equal
Mhm.
member of the team. And also, like you said, spend the most time with the child and have known the child for longest, right?
Mhm.
I know another area of your specialty is accent acquisition and working with bilingual families. So you have a certification and background in accent modification and
Yes.
acquisition. So can you talk a little bit about this work? So how does that intersect with supporting bilingual families or children who are learning English?
Yes, yeah. It's important to keep in mind that an accent is not a disorder, so this is not something that's covered through insurance. Difference does not equal disorder. And accent acquisition is really interesting. And multilingual children, they're oftentimes either over-identified in schools or under-identified in schools, just kind of depending on the place and the context. But I don't work with this will oftentimes come up in assessments, and it's important to understand so that you can conduct something called dynamic assessment. But if you're looking at something like accent acquisition for adults, they're typically trying to get a raise and people at work don't understand them. And sometimes their accent has something to do with it, but oftentimes it's more their confidence and their presentation skills. And so we'll work a little bit on accent, but oftentimes we'll work more on their presentation. And so it becomes part accent, part presentation
Mhm,
because accent is such a big and important part linguistically and culturally of who you are.
mhm, mhm,
Your accent, you can oftentimes work around if your presentation skills are able to overcome so much of your accent. And your accent can really get in the way of intelligibility, but there are typically workarounds.
mhm, mhm. That's really interesting. So you work with children and adults in this space, it sounds like.
Yes,
And I'd imagine different, it's different probably based on stage of life and functional demands of a classroom versus a workplace.
completely.
Hmm. And when you said that kids tend to be under-identified or over-identified, I completely know what you're saying, where sometimes you see, well, it's, the difference is due to second language acquisition when it's really not, without really digging deeper, or over-identified of, pathologizing normal acquisition. So it is a really tricky intersection. And when you see the misidentification and well, I guess, yeah, just misidentification. Is that in like stuttering or fluency or again, social pragmatics, like autism, or just kind of everything across the board that can be misidentified?
Everything across the board, but there's a huge racial and cultural component. So you'll see oftentimes like um, African American speech. That is so over-identified. Children uh, who exhibit characteristics of African American speech being over-identified and having goals like tense. And that's not a disorder, that's a difference. And we need to be so cognizant of that because that's just this wonderful cultural part of this child. And it's not a disorder, but it's still over-identified.
Hmm. Hmm.
We have to be so careful and employ so much cultural humility to our speech practice as we are often employing these speech tests in our identification of students, these assessments that we're using to identify students to qualify for services are very typically not normed for children who are not white. And that's problematic. So
Hmm.
dynamic assessment is going to be our best friend as we're looking at students who are culturally and racially diverse.
Hmm. 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 Okay, thank you for that example. So, in terms of neurodiversity affirming care, so when you're working with a young child on the autism spectrum, how do you balance teaching functional communication while ensuring a neuroaffirming approach? And we did talk about this a little bit earlier, but are there any other comments or specifics on autism in particular with neuroaffirming speech and language services?
I think just the last thing that I'd probably leave you with here is that with neuroaffirming care, our goal is not to make autistic children look typical. Our goal is to help them to communicate and to connect and to thrive. And my hope for the world of speech therapy, at least, is that we deviate more from goals that are specifically for neurodiverse students and more toward goals for both team members. So, goals for the student and goals for the therapy provider,
Hmm.
where we have maybe a goal for the therapy provider to use more typical echolalia or gestalts that are meaningful to that student, or to explain some um, feelings that we're having so that the neurodiverse student doesn't have to interpret our body language so much because of how taxing that could be for the student, or to affirm that we're having a good time in our play, even if it doesn't look neurotypical. Just something to meet them halfway, because it's so unfair that the student who is neurodiverse has to do all of the hard work and the change when there's no expectation on us as the therapy provider to meet them halfway.
I really like that framing goals for the therapist too. Okay, and lastly, kind of close out our conversation. So you see families at all stages of their journey. So starting in early intervention and moving to complex school systems, and as you talked about, even some work with adults. So what's the most important message you want parents to hear if they are feeling overwhelmed by their child's speech, language, or educational needs? Any closing advice?
Oh, oh, parents, you are doing so much better than you know, and you're not alone. As therapy providers, we're here to listen. I know I am here to listen without judgment. And if you have a good therapy provider, they will listen without judgment too. You don't have to be the perfect parent to make a profound difference in your child's life. And any good therapy provider for your child is going to understand that too.
I like that. I also tell parents, especially as a parent, we get it. Like we know how busy you are. And so it can be overwhelming when we're like, here's 20 things you can do, right? Here's a list of things. And I always couch that with, and we know how much you're doing already. And like you said, it doesn't have to be perfect, but meeting
Yeah.
people where they are and being practical and on the ground. Well, thank you so much, Liz. I know I learned a lot from our conversation. I'm sure our parents will too, and appreciate your time today.
Yes, thank you so much for having me. This has been wonderful.
And we'll put your clinic's information in the show notes, but is there anything you want to share of how parents can reach you?
You'll have my website information, and you can also, um, yeah, please just feel free to reach out to me from the website at any point if you have any questions about your child's speech and language development, and I would be more than happy to chat.
Okay, perfect. So sounds like the best way to get a hold of you is through the website, which we'll have in the show notes. So thank you for your time today, Liz.
Absolutely. Thank you.